Hello, I'm Linda Duska, your guest host of the ASCO Daily News Podcast today. I'm a professor of obstetrics and gynecology and serve as the Associate Dean for Clinical Research at the University of Virginia School of Medicine. On today's episode, we'll be discussing a new standard of care for previously untreated, high-risk, locally advanced cervical cancer. This follows the NGOT-CX11 GOG 3047 KEYNOTE-A18 study, which I will be referring to as KEYNOTE-A18 for the rest of this podcast, which demonstrated that pembrolizumab plus chemoradiotherapy improved both progression-free and overall survival compared to chemoradiotherapy alone. I was a co-author of this study, and I'm delighted to be joined today by the study's lead investigator, Dr. Domenica Lorusso, for today's discussion. She is also a professor of obstetrics and gynecology. She's at Humanitas University Rossano and the director of the Gynecologic Oncology Unit at the hospital in Milan, Italy. Our full disclosures are available in the transcript of this episode. Dr. Lorusso, it's great to be speaking with you today.
Thank you, Linda. It's a great pleasure to be here. Thank you.
So I was hoping you could start us out with some context on the challenges associated with treating patients with high-risk locally advanced cervical cancer.
Yes, I have to make a disclosure because in my experience as a gynecologist, cervical cancer patients are the most difficult patient to treat. This is a tumor that involves young patients with small kids. This is a very symptomatic tumor. More than 50% of patients report pain. Sometimes the pain is difficult to control because there is an infiltration of the pelvic nerves and also a kind of vaginal discharge. So it's a very difficult to treat tumor. Since more than 25 years, after the publication of 5 randomized trials that demonstrate that when we combine platinum chemotherapy to radiation treatment, we increase overall survival by 6%. This is the new standard of care, concurrent chemoradiation plus brachytherapy, and which is a good standard of care because particularly modern image-guided radiotherapy has reported to increase local control. And local control in cervical cancer translates in a better overall survival. So modern radiotherapy actually is able to cure about 75% of patients. This is what we expect with chemoradiation right now.
So what are the key takeaways of A18? Really exciting trial. You've presented it a couple of times. Tell us what are the key takeaways that you want our listeners to know.
Linda, this is our trial. This is a trial that we did together. And you gave me the inspiration because you were running a randomized phase 2 trial exploring if the combination of pembrolizumab to concurrent chemoradiation was able to give signals of efficacy, but also was feasible in terms of toxicity. There were several clinical data suggesting that when we combine immunotherapy to radiotherapy, we can potentially increase the benefit of radiotherapy because there is a kind of synergistic effect between the two strategies. Radiotherapy works as a primer and immunotherapy works better. And you demonstrate that it was feasible to combine immunotherapy to concurrent chemoradiation. And KEYNOTE-A18 was based on this preliminary data. We randomized about 1,060 patients to receive concurrent chemoradiation and brachytherapy or concurrent chemoradiation and brachytherapy in combination with pembrolizumab, followed by pembrolizumab for about 2 years. Why 2 years? Because in most part of cases, in more than 80% of cases, recurrence in this patient occurred during the first 2 years. So the duration of treatment was based on the idea to provide protection to the patient during the maximum time of risk. And the trial had the 2 primary endpoints, progression-free and overall survival, and met both the endpoint, a significant 30% reduction in the risk of progression that was confirmed at the 3-year follow-up. The acceleration was even better, 0.68. So 32% reduction in the risk of progression, and more important, because this is a curative setting, 33% reduction in the risk of death was reported in the experimental arm when pembro was combined with chemoradiation.
That's amazing. I wanted to ask you, a prior similar study called KALA was negative. Why do you think A18 was positive?
Oh, Linda, there are several discussions about that. I had the possibility to discuss several times with the PI of KALA, Brad Monk. The idea of Brad is that KALA was negative because using durvalumab instead of PD-1 inhibitor, which is pembrolizumab. I do not have exactly the same impression. My idea is that it's a kind of patient population enrolled. The patient population enrolled in KEYNOTE-A18 was really an high-risk population. 85% of that patient had node positive, where the definition of node positivity was at least 2 lymph nodes in the pelvis with a short diameter of 1.5. So we are very confident this patient had node positive. 55% at the grade 3 and 4 disease. So this is really an high-risk population. I remember at the first presentation of KALA, I was honored to discuss the KALA trial when it was first presented in IGCS few years ago. And when I received the forest plot of KALA, it was evident to me that in patients with stage 3 and node positive, there was a signal of efficacy. And we have a huge number of patients with node positive. So in my opinion, this is the reason why KEYNOTE is positive.
Yeah, I agree with you. I've thought about it a lot, and I think you're right about that. The Interlace trial results were recently published. How should we interpret these results in the context of A18?
So it's very difficult to compare the two trials. First of all, in terms of population. The population enrolled in Interlace is a low risk, locally advanced, but low risk population. 76% were stage 2, 10% were stage 1, 60% were node negative patients. So first of all, the population is completely different. Second is the type of radiotherapy that was provided. Interlace is a 10-year long trial, but in 10 years, the quality and the technique of radiotherapy completely changed. Only 30% of patients in Interlace receive what we call the modern image-guided brachytherapy, which is important because provide local control, and local control increase overall survival. And third, we read the paper. I'm not a methodologist, but there are some methodological bias in the paper. All the statistical design of the trial was based on PFS, but PFS was evaluated at physician discretion. And honestly, I never saw a trial that had a no pre-specified timeline for radiological evaluation. It's very difficult to evaluate progression in cervical cancer because the fibrosis related to radiotherapy change the anatomy in the pelvis. And I think that radiological evaluation is important to address if the patient is progressing or not, particularly because the conclusion of KALA is that the PFS was mainly in favor of distant metastasis. So really, it's difficult for me to understand how distant metastasis may be evaluated with the vagina visit. So really, it's very difficult to compare the two trials, but I have some concern. And also because of toxicity in the study, unfortunately, 30% of patients did not complete concurrent chemoradiation because of residual toxicity due to induction chemotherapy. So I want to be sure in the context of modern radiotherapy, if really induction chemo adds something to modern radiotherapy.
Well, I have two more questions for you. As we move immunotherapy into the front line, at least for these high-risk, locally advanced cervical cancer patients that were eligible for A18, what does that mean then for hopefully those few that develop recurrence in terms of second-line therapy?
Well, Linda, this is a very important question. We do not have data about immuno after immuno, but I would not completely exclude this hypothesis because In KEYNOTE-A18, the patient received treatment for a well-defined time period. And for those patients not progressing during immunotherapy, I really guess if there is a space for the reintroduction of immunotherapy at the time of recurrence. In this moment, we have 30% of patients in KEYNOTE-A18 in the control arm that receive immunotherapy after progression, but still we have 11% of patients that receive immunotherapy in combination with concurrent chemoradiation and then receive again immunotherapy in later line of therapy. I think we need to collect this data to capture some signals. And for sure, we have the new drug. We have antibody drug conjugate. The trial are ongoing, exploring the role of antibody drug conjugate, particularly anti-TROP1 in immune pretreated patients. So I think this is a very interesting strategy.
I was going to ask you what are the next steps, but I think you already answered that question. You talked about second line. If you were going to redesign a study in the front line, what would it look like?
Probably one question that I would like to answer. There are two questions, in my opinion, in KEYNOTE-A18. One is induction immunotherapy. Linda, correct me if I'm wrong. You reported very interesting data about the immune landscape change when you use induction immunotherapy. And I think this is something that we need to explore in the future. And the second question is the duration of maintenance. Because again, we decided for 2 years based only on the epidemiology of recurrence. But I guess if 1 year may be enough.
I think this sequencing question is really important. That the induction immunotherapy was actually GY017. I can't take credit for that, but I think you're right. I think the sequencing question is really important. Whether you need the concurrent IO or not is an important question. And then to your point about the 2 years, the length of the need for maintenance therapy is a question that we don't know the answer to. So there are lots of really important questions we can continue to ask. I want to thank you so much, Keta, for sharing your valuable insights with us on the podcast today. You're always so thoughtful about this particular study and cervix cancer in general, and also for your great work to advance the care for patients with GYN cancers.
Thank you, Linda. It's our work. We increase together.
Yes, and we thank the patients as well, the over 1,000 patients that went on this trial during a pandemic, right?
Absolutely. Without their generosity and their trust, we could not be able to do this trial.
Yes, so we're very grateful to them. And we thank our listeners for your time today. If you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. Thank you all.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.